Hi, everyone. Welcome, welcome. Let's
Hi.
just wait for people to join.
Yes,
You're
please
welcome to
join
say
us.
hello. You're welcome to say hello in the chat. Hi, everyone. Just a couple of seconds so people can join. Hi, Claire from Brisbane. Welcome. Very early in Australia, so welcome. Think we're probably going to start, not to delay much. So, hi, everyone who's watching. Tell us who you are, where you're watching from. We would love to hear about you. And please interact in the chat box as much as you want. Welcome to this first session of the 4-day challenge, where we'll be discussing all things lifestyle medicine in oncology. My name is Diana Ferreira. I'm a physician. I'm certified in lifestyle medicine. I hold master's and a PhD in palliative care, and I work for the AIM Cancer Center in Portugal. And also, I'm a lecturer in ESLO, the European School of Lifestyle Oncology. And I'm joined today by my colleague and friend, Annabella. She's an oncology nurse who brings a wealth of expertise to this discussion. So welcome, Annabella.
Thank you, Diana. Hello, everyone. Welcome to our first day in this 4-day challenge. I'm so glad to be here, and I hope everybody enjoy and appreciate what we prepare for you.
Yes, absolutely. So I'm going to share my presentation. Let's see. Give me just a second. Can you see it? I hope all is well. Annabella, can you see it properly?
Yeah, it's
Yes.
okay.
Okay, brilliant. All right. So again, we'll be talking all things lifestyle medicine in oncology. And let's just start with day one. This is Beyond the Tumor, exploring the hallmarks of cancer from cell to whole person. This is the title of the presentation today. And I would love to start by letting you know that a revolution is underway, whether you know it or not. But in fact, the way we understand and the way we treat cancer is undergoing a profound transformation. And we can feel it in the patients that come to us. Many of us felt it as cancer patients ourselves. So these are challenging times, but also exciting times. And I want to start by talking about this concept of the hallmarks of cancer. I don't know if you're familiar with those. If you're a health professional, it's very likely that you are. But I want to mention the beginning of the hallmarks of cancer, what led to those, to the development of those. And cancer. So this was a group of researchers that completely understood that cancer is a very complex disease at all levels: genetic, histological, pathological, prognostic, therapeutic, etc. And they asked themselves if they could systematize this complexity, and if there were common principles underlying this complexity to make it accessible and simple, or as simple as possible. And what are the hallmarks of cancer? So this was actually published in article in 2000, and these were defined as acquired functional capabilities during tumor development that are common to all cancers. This is basically what makes cancer cancer and not any other disease, what allows us to say something is cancer. And it also, understanding those also allows us to develop effective interventions. So these are very relevant. They were relevant in 2000, and they were very relevant for the development of interventions over the past 20 years. So the original publication was from 2000, as I said, and they proposed 6 hallmarks of cancer. So the first one was the capacity to sustain proliferative signal. So cancer cells can actually continue to replicate. But they also need to be able to evade growth suppressors. They need to be able to avoid these suppressors of growth that are very effective to stop growth in healthy cells. Beyond that, they need to be able to invade other tissues, to metastasize. So this is a capacity that is very unique to cancer cells, actually. And they can continue to replicate. So most cells have sort of a limited number of cell cycles they go through. And then they die or they stop replicating. And in cancer cells, this doesn't happen. So they continue to replicate indefinitely. There's also the capacity within tumors to induce angiogenesis, which is the formation of new blood vessels that continue to feed the tumor and allow for progression and for growth. And then, of course, they resist cell death, which is, again, a very normal it's very normal when it happens in normal healthy cells, but resisting cell death, it's one of the aspects that allow tumor cells to continue to grow and develop. So these hallmarks, as I said, were published in 2000, and the next iteration of the article was published 11 years later, and they proposed new hallmarks. So they kept old ones, but they were discovering other aspects that make cancer cancer. So one of these aspects was the regulating cellular energetics. So we understood that cancer has a way of just disrupting the way energetics works in cells and sort of taking advantage of that. They have the ability of avoid immune destruction. We know that it's driven by genome instability and mutation. And also we understood the role of inflammation as something that also promotes tumor formation and development. And here we also talk about tumor microenvironment. So we start to understand that it's not only the tumor itself, but there's also the capacity to recruit cells that are around the tumor and that support the tumor to form an environment that is very favorable to cancer progression. So we expand a little bit of our view in this 2011 iteration. And then another 11 years later, in 2022, we proposed they were proposing new hallmarks in addition to those. So here we understand that cancer cells, they start as very undifferentiated cells, and as all cells do, but instead of differentiating, they can differentiate, they can arrest and stop differentiation, and they can also go back to previous stages. So they're very plastic. They can just adapt to the environment. And then senescent cells, this is a capacity that all cells have, healthy cells, to go into a dormant sort of state and stop replicating, and which doesn't necessarily happen in cancer cells. And then there was not only the genome, but also we know that there's factors regulating gene expression that are also super important in cancer. So we talk about epigenetics that most of you probably heard about. And then in this paper, we start also talking about polymorphic microbiomes. So it's not, we understand that within the cell, within the tissue of cancer, there can be disruption of microbiomes, but also in other parts of the body. We talk about the gut microbiome, even when we have breast cancer or prostate cancer or any other type of cancer. So here we expand our view. We're not only focused on cancer, we're focused on distant tissues and environments as well. And finally, this was a new update from 2024, so it's fresh out of the oven. And I really encourage you to have a look at this paper if you haven't. And here, what I find really interesting is that we stop talking about the hallmarks of cancer, we start talking about the hallmarks of systemic disease, and we start recognizing that cancer is quite complex and that develops within a certain context, and all of that contributes to its expression in the human body. So there is extreme diversity in the mechanisms and manifestations of cancer. We know that this happens between tumors, but also from person to person. And we need to think beyond the cancer to understand this diversity. So in this particular paper, which is so interesting, they propose mechanistic effectors, which what you see below the horizon in the figure, and these are the building blocks of cancer. So that's what you can see, basically, governing the inception and progression of cancer. They're not completely understood, but they exist and they can be seen. And then you have complexity clouds, which may help to explain the diversity in mechanistic effects and phenotypes. So we talk about factors that can contribute to cancer and increase the complexity. And this is the first time that in one of these papers we hear about lifestyle factors. We hear about obesity and physical activity. We can see that they mention dietary influences, circadian clocks, which is much more than sleep, but also involves sleep. We mention metabolic effects, and all of these are contributing to the development and to the expression of cancer. And the authors say at some stage in this article, elucidating both dimensions of cancer, the clouds of complexity and the mechanistic effectors, as a systemic disease, will be instrumental for groundbreaking innovations in prevention and enduring treatment of human cancer. So we will see more of that over the coming months, years. They also start with the genesis of cancer, how it starts, basically. And again, lifestyle factors here. For example, you have obesity, diet, and also inflammation coming from these that may contribute indirectly to driver mutations that can stay dormant, and then they can be influenced or suffer the effects of selective pressure caused by endogenous and exogenous processes that again are related with lifestyle. Exposure to microplastics, for example, PFAS, infections, smoking, but also endogenous processes like obesity and diet, stress, sleep deprivation. All of these are important just in the generation of cancer. And then we have here probably the most interesting figure in the whole article, highlighting cancer as a systemic disease. So they highlight 3 levels of influences. We're talking about the microenvironment that we spoke before, so what's around the tumor, but also we're talking about the macroenvironment, the terrain where the tumor is developing the human body, what's happening there, what facilitating factors are present, what helping factors are present. And then we talk about the external environment overall. And here, again, lifestyle, food intake, stress, circadian rhythms, microbiome, aging is something that we can't necessarily change, but most of these factors we can actually change. And this is also an interesting aspect of the complexity of cancer. And so we knew before that disruption of systemic metabolism and energy production was happening in the cancer process. But now we know that this is not only a consequence of cancer, but a requirement for cancer development and progression. And even here in this disruption of systemic metabolism, lifestyle factors like exercise, diet, and even the microbiome play an important role. So when we're acting in these factors or changing these factors, we're working with different aspects of cancer at the beginning. The macroenvironment, we're also working with aspects related with the energy production. So they're beneficial in so many ways. So we are really having a change of paradigm in oncology. We started in the 2000s, in the beginning of the 2000s, focused on the tumor with a more detailed vision. We were very genetic oriented, and now we are developing a broader vision of cancer as a systemic disease. We know that it's not only genetic, but metabolic, environmental contributors play a role. And also, we don't fully understand the interaction between these contributors, but it is highly relevant. And also, we need to understand the person's context, because we won't make changes unless we really understand where the person is coming from and their context. So, complex problem cannot be solved with only one solution. So treating the cancer itself, and if you are a cancer patient, you will understand this quite well. This will not be enough to respond to all of our needs. So we need a broader perspective of the person where cancer develops. And I want to talk about integrative and lifestyle medicine here, just about the concepts, so we know what we're talking about. So integrative medicine is the integration of conventional medicine, lifestyle medicine, and complementary medicines or therapies. It's based in the best available scientific evidence, so we don't necessarily accept any intervention. It needs to be based on evidence. It's focused on whole health. So we're talking about the body, the mind, emotions, and spirit. We recognize that the person is an integrated being and not only the cancer. And this is a recent paper published in the Journal of Clinical Medicine, where the authors say growing evidence indicates that the important role of integrative oncology on outcomes in cancer care, with most studies indicating improvement in symptoms and quality of life, including pain, nausea and vomiting, anxiety, hot flushes, insomnia, neuropathy, and dry mouth. So we need to look into the evidence here. And just talking about a few concepts to clarify what we're talking about. So conventional medicine, it's the medicine we all know. Patients usually have a passive role. It's very much focused on diagnosis and disease management and very much focused on pharmacological treatment. Complementary therapies, we all heard about them as well. So we're talking about interventions like acupuncture, acupressure, yoga, that are used in addition to conventional treatment. So they complement traditional or conventional treatment. Alternative therapies are very similar, but they're used in alternative. So in our center, we use complementary therapies and not necessarily alternative therapies. Then lifestyle medicine, very much focused on optimizing lifestyle to improve health. We see patient as a partner in decision-making. The patient has an active role in improving health and preventing disease. And these are usually long-term interventions. So these two aspects are super important because we as health professionals work with patients for a very short period across the week or the month, and then they go home and they have to live their lives and they have to adopt behaviors that will be favorable to them. So they do the work. So we need to have them as partners. We are not the center of the treatment, let's say it that way. And we talk about long-term interventions because we're not only thinking about the treatment period, but we're actually thinking about long-term changes that people can implement. And we're talking already about survivorship as well. So how can we improve these persons' quality of life and life beyond cancer? And then medication, of course, can be used together with lifestyle changes. And integrative medicine, as I said before, is actually broader than this because it integrates conventional medicine and evidence-based complementary therapies. And is focused on all domains of health, not only the physical, but the mental, emotional, social, spiritual. So why do we propose lifestyle medicine? Because 70 to 90% of all cancers are caused or have its origin somehow in environmental factors. So we're talking about lifestyle, but also infectious agents, radiation. So it's very much lifestyle driven. And I want to let you know as well that there's lots of different organizations and institutions that are adopting this way of caring. The Society for Integrative Oncology is an international organization that you can all have a look at. The British Society for Integrative Oncology, but also the Memorial Sloan Kettering has a program in integrative oncology for patients. The MD Anderson Center in Texas, the same. They have an integrative medicine center, and Harvard Medical School as well. So these are just a few examples. I'm sure there's something local to you as well. So we can't really ignore this lifestyle revolution. It's already underway. We know it's happening. So we need to pay attention also to what the patient's needs are and start making a difference in our own practice. So yes, and letting you know that we all moved from just the conventional approach to the lifestyle integrative medicine approach. So I believe we can all do it as health professionals. And this is a challenge for you. Are you ready to discover and to how to expand your professional practice? And we will continue our journey tomorrow. But for today, we have a special guest. So I'm just stopping my presentation. Sorry. So today we have a very special guest. We have Associate Professor Kate Swettenham directly from Australia with us. She's a registered nurse who is the Director of Nursing for the End of Life Care team in the Department for Health and Wellbeing in South Australia. Kate holds qualifications in general nursing, psycho-oncology, palliative care, and holds a Master's of Science where the introduction and implementation of a nurse-led palliative care clinic was the focus of her research. Kate is also a member of the Research Centre for Palliative Care, Death and Dying at the Flinders University in South Australia, and the president of Palliative Care Nurses Australia. I could be talking about Kate all day, but I'm very excited to welcome Kate into our conversation. Hello there.
Hello, Diana. Lovely to see you.
Yes, we haven't seen each other in a while, so it's lovely to see you, Kate. I'm joined by my colleague Annabella. She's a registered nurse as well, so very much many things in common with you.
Yes.
And yes,
welcome, Kate. Thank you
Thank you,
for being with us.
Such a pleasure.
And we would like to start by asking you, Kate, because you started as an oncology nurse. And tell us a bit about your journey and what led you to be an oncology nurse? What inspired you to do it?
So I think it's probably shrouded in my early childhood experience. So my father was diagnosed with a malignant brain tumor when he was 40, and he died when he was 41. And I would have been 10 years old around that point of diagnosis, and then when he died. And in 1976 and 1977, there was very little, particularly in South Australia, for people like my father. Palliative care did not exist as a specialty. And my mother, who was much younger, she was 33 when he died, had 4 small children. So I was the second of 4, and my youngest sister was 6. And she was trying to manage a family and manage a dying husband and care for him at home. And when he was diagnosed, he was given 3 days to live because they had operated on the tumor, and it was technically an inoperable brain tumor. So they had after his surgery had said to my mother, we give him about 3 days. And so she went from a husband who had a seizure, which was atypical, and they thought that there was maybe a blocked blood vessel, is what they said when they went in to operate, to then coming out of that surgery being told that he was terminal and that there was nothing for him, other than to, that he probably wouldn't get out of hospital. So he refused. He refused traditional medicine, and he used alternative therapies, which as a child I remember struggling with because it actually seemed to cause him quite significant trauma. He was on a very, very restricted diet. He was eating almond kernels, which have got arsenic in them. We would have dinners where we as a family would be served one meal and he'd be served something that just looked hideous. and he would be crying at the table asking where was his dinner. And I just remember being a very small child thinking, this is just all so wrong and so difficult. I knew that my mother was trying to keep him alive. She couldn't imagine her life without him. And, you know, he succumbed to his illness 9 months after he died. And so, 9 months after he was diagnosed. And so he needed to, you know, we probably needed him to live and suffer and journey through that for us to be ready to recognize that it was a big ask to keep him with us and that it was time for him to go. So then, you know, that happens when you're in your very kind of formative years, and I had to get through school. And when I finished school, I had thought I probably would become a nurse. My grandmother had said at the time that my father was dying at home that she used to say, oh, Catherine will be a nurse one day. She's so marvelous with her father, because I used to climb up on the bed and get him things that he wanted and wasn't afraid of him and his illness. And so I think that probably shaped it. And when I started my nursing, I actually started as a pediatric nurse. So I was in the days that I trained, which is a long time ago now, we trained in hospitals. And I went to the Adelaide Children's Hospital as a nursing student and did my training there for 3 years and found myself in the cystic fibrosis ward. And in those days, children with cystic fibrosis didn't live often to adulthood. We lost a lot in their early and teenage years. And of course, the development of heart and lung transplants came in after I'd finished in that ward, and I started to see children that I had looked after actually entering adulthood with, the advances in technology. So when I finished my training and thought I was going to be a pediatric nurse for the rest of my days, was really fascinated when I made the decision that actually I wanted to explore adult nursing, and with that was the desire to go into the cancer space and see, could I make a difference, or, could I at least understand what had happened in our childhood and try and understand it through more adult eyes than a child's eyes. And so I think that's really how I got there. And interestingly enough, I would say that my cancer nursing was a transition point into palliative care, which is where I have spent the majority of my nursing career now. And probably the reason for that is because palliative care is grounded as a multidisciplinary, interdisciplinary team approach to patient care. And I recognise that not one clinician can actually meet the needs of a person. Each patient is a very complex individual, and they bring an entire story behind them, which needs to be explored if we're going to care for them properly. And I did find that moving into palliative care enabled me to actually unpack that better, and probably opened up my interest in the area of psycho-oncology, where I learnt really about our cognition, our behaviours, and the impact that it has on cancer development. So long answer to a very short question, Diana, but that is probably how I found myself here.
No, thank you. That's brilliant. And I think I have if I think about it, the multidisciplinary aspect of palliative care, I think it's what attracts us in the first place, and would love to bring that to the oncology space as well. So go ahead, Annabella.
Kate was saying that was a big answer. I don't think so, because the key word was journey, and a journey like yours, I think you resume it very well. But I'm amazed by your expertise. Your CV is something that makes me go further. You inspire us to be better. And the way you talk about palliative care resounds on me, all the things that I believe also. So do you want to talk about the needs of patients and what we can do better by doing together the approach, not only palliative care, but also in oncology, since you have both experiences?
Look, I think the patients taught me so much. And I think never lose the opportunity to pull up a chair and really get to know them. And I think in nursing, we get that wonderful opportunity, particularly when I was putting cannulas into people's veins and then sitting next to them and dripping in a cytotoxic treatment for them, that, I always had a choice to make. I could make the choice of, oh, look at the weather out there. It's pretty blowy today. And, I hope you didn't get wet coming in today. I could have kept it very superficial. Or I would make the choice to say, how is this for you? How are you coping and managing with everything that's happening around you? And quite often you would just see the tension just slip away. They think, oh, here's someone who's genuinely interested. I don't have to be brave. I even don't have to fight today. And I think that's what used to stagger me, was the pressure that was put on people, that cancer was always represented in our printed media, in our newspapers, as a battle that could be won or it could be lost. And I think what I used to find with patients was the pressure to win that battle. If they didn't, if the disease was advancing or progressing, they felt that they were failing. So not only, there was language that got used, which I found very, very troubling. We had an oncologist that used to say, oh, you failed chemo, so now we're going to try, radiotherapy. And patients actually took that to heart. I failed chemo, so there's something wrong with me. And I used to have to sit there and turn it around and say, no, chemotherapy failed you. In this instance, this line did not work for you. It's got nothing to do with you. You didn't fail. And I used to find this whole analogy of battle, failure, whether you win, whether you lose, was a big source of suffering for our patients. And I felt it was very, very important that we kind of drill down and really, I learnt from a very young age that you can do a lot of good by going for a strengths-based approach. What have they been successful with in their life in the past, prior to cancer? Tell me your story. Where, what were some of the things you were really proud about? What challenges did you face that you have overcome? Because that's what's going to see you through now. Not whether the chemo is the right chemo for you or not. It really is about, can we build on the strengths that exist deep within you? And for some people, they had buried them, and it was very hard to really help them find them. But I did used to think that it was a responsibility when I was sitting giving people chemotherapy, and I had this beautiful opportunity to have very meaningful conversations with people, to not let 1 minute go to waste.
Yeah.
So that was probably my approach.
Yeah, no, that's brilliant, Kate. And I want to draw, and I know it was in the palliative care context, but you had an amazing sort of project in the clinic when I went to Australia to meet you the first time, and it was like a different station process for different patients, and I get for with different needs being met, but. And I know it was in the palliative care context, but I can see that working as well in the oncology context with a few adaptations. And can you tell us a bit about the project, but also your experience with the project? Because I think it was one of the most interesting things I've experienced in Australia.
Well, thank you for that. Look, I think what happened in Australia, quite often we get given new money to do things, but it's for a short period of time. And so in this instance, we were given some new Commonwealth money to improve palliative care. And we had just started employing nurse practitioners in our service. And I felt that there was a need to actually demonstrate a model where nurse practitioners could really work to the full scope of their practice. And so we had been, the service that I was working in had been a research centre. And so we were used to actually applying research questions and really having a think about what might be the next step. So one of the things that had fascinated me was this notion of early introduction into palliative care. So there had been a study done by Tumor where they put lung cancer patients alongside palliative care intervention. And those patients with lung cancer actually had better outcomes, actually lived longer because they had actually been introduced to palliative care and were actually able to start thinking about the holistic aspect of their illness. And so I thought, well, what would it look like if we had an early introductory clinic to palliative care for people that are still reasonably well, that can tolerate they need to be able to tolerate a 90-minute consultation. But what would it look like if we actually structured in a session where the patient and the caregiver were actually separated? So we invited the patients to bring their caregiver so that they could hear the physical information through the nurse practitioner. They then travelled from that 30-minute assessment to the social worker, who kind of really looked at the patient particularly, but gave some credence to the caregiver to look at what their social supports were and to identify were there other things that could be impacting on the ability for this person to be managed at home, such as was their housing secure, were they financially stable, were they accessing any financial supports that might be available to them that they yet didn't know about. Could they have access to disability parking so that they didn't have to walk too far for appointments? So all that type of stuff was covered in the social work assessment. And then we separated them. So we sent the patient came and saw me, and I worked as a psycho-oncology nurse. And the caregiver went to the person that we called our network caregiver facilitator. And her role was to really look at the needs of the caregiver. It was a fascinating clinic, and we applied research to it because with everything that's short-term funding, any chance to keep something going does need a degree of evidence to sit underneath it. And the evidence was pretty compelling. And what it showed was that when the patient and the caregiver were together, the primary focus was on the patient, and the caregiver had very little to contribute or was or even engaged at a very little level by the clinician. But when they were separated, their caregiver spoke more in their clinic than their clinician did, and that was the only clinic where we had the non-clinician speaking the most, and they had a lot of emotional issues that needed to be addressed that they didn't feel that they could open up about with in front of the patient. And equally, the patient, when they saw me, they also had very emotional conversations that they didn't feel that they could have in front of the caregiver because they didn't want to be seen as not coping, and they didn't want to add any additional burden to what was already a challenging environment at home. Occasionally, I would see a patient who didn't care if the caregiver was crumbling under the weight of caregiving. That was very much in the minority. The majority of patients, once they recognised that dying for them was going to be similar to what birth is, with a brand new infant that needs lots of care and attention in order to be nurtured through, that dying was also going to require someone there to provide care and attention if they were going to stay at home. They actually the majority of people, I'd say probably 95% of patients that I spoke to said, what are my options? Because I don't want to place any unnecessary burden or duress on my partner. The majority of the patients coming through the caregiver was more often the spouse. So it was a fascinating clinic, and it really gave people a great understanding of what was ahead. And we did it deliberately in the early stage because we actually said, look, we may not see you again for 12 months, 2 years, or may not see you again at all. We had some patients that came through that clinic that had metastatic melanoma, and immunotherapy was just coming into its own, and we actually discharged people off our books. They actually got well and went away. But I've had one of those patients in particular come back to me and say that clinic was the thing that absolutely made the difference between me coping and not coping, and actually understanding the journey that was ahead and being able to make some practical decisions around that. She found, it really did set her up for good well-being with her illness. And I think that's what that early introductory clinic was all about, was focusing on the well-being.
Thank you, Kate. While Annabella asks the next question, I'm just going to say to the people who are watching, if you have any questions for Kate, please go ahead and put them in the chat. And we have a bit of time for that as well.
Kate, when you talk about your model, your approach, I thought about the communication aspects and how it was probably the main thing in your approach to communicate with patient, with caregiver. But how do you handle situations when patients or caregivers become emotional distress or angry during your conversations? You talk about sensitive content. Is it so?
Look, you know what? It was very unusual for them to become angry. They did become emotional and distressed. And I suppose the main thing was to normalize it. That this, your life as you have it planned out in your mind has just encountered a major obstacle. And it is absolutely important to grieve the loss of your hopes and your dreams. And what's important once you've done the grieving is to reframe your hopes and your dreams. So what have you still got control of? What can we continue to support you so you remain really in the driver's seat of your life until the point that you really can't do that anymore? So again, I think I've said it already once, but that idea of a strengths-based approach, what is it within that individual? And so I think that's what psycho-oncology taught me, was don't accept anything at face value, develop a healthy respect for, a healthy degree of curiosity, and ask questions. Don't be afraid of emotions. Patients will tell you if they can't talk with you about it. They will absolutely say, look, I can't do this. Then you respect that and say, completely understand. If you feel at another time you would like to talk with me about it, I'm here to do that. So it was always a case of balancing between the cues that you get from the patient and being a little bit brave, just to ever so slightly push them to the next stage and see if they were willing to go there. I remember one of my colleagues used to say there's two types of patients. There's the information seekers and there's the information avoiders. And you do need to understand the difference between the two. The information seekers will be self-evident because they more than likely will come to your consultation with a whole lot of papers that they have got off the internet, and they'll want to discuss them in great detail about all possible treatments that they've been exploring for themselves. The information avoiders will often be, oh, talk to my wife, talk to my husband, not interested. And I used to think initially, we've got a job to do. We've got to help them understand that their life is short. But I learned very, very quickly that information avoiders doesn't mean that they don't know what's going on. They cope and manage by not being immersed in what's going on. And I've had plenty of those people say to me, I know that I'm dying. And it's almost like the moment they say that, you go, oh, thank God, I can stop. I can stop exploring this because they know, So then you go, what is important to you now? What is it that you would like to do? And actually, if you get people talking about themselves and still, again, reconnecting with their hopes and their dreams, invariably any distress that they've got will be worked through. And so, it does require a degree of bravery. But I think the other thing that's really important, don't ever be afraid of silence. Sometimes just sitting in the space and not saying anything is the greatest therapeutic tool that you can offer somebody. And so it is that case of you don't have to fill the silence with words. You can just let it sit And eventually someone will say something.
Thank you. And maybe you touched on that already, but what do you think as health professionals? And I know palliative care is a special field, but maybe in other fields, what are we missing in terms of what are the needs of the patients, basically?
Look, I think it's what are we missing? We do get very distracted by the environment in which we care for our patients. And it's really hard not to get distracted. I think about Australia post COVID-19, and we have this new phenomenon of ambulances ramping out the front of hospitals and can't get patients into emergency departments because the emergency departments are already full and the patients coming in can't get in. I don't know if it's happening in Europe, but it's certainly happening here. So what does that do? It puts pressure on every ward in the hospital to try and clear patients out who may just be through the acute part of their illness, but not quite well enough to be home managing alone. And you just put people on a conveyor belt of, trying to address one problem by actually creating another. And I think that, with patients being able to hear what their situation actually is, we can't solve everything. I recognise that. I now work as a bureaucrat, so I know the landscape, and we can't keep patients that need convalescence in acute hospitals for long periods of time like we might have done in the 1950s. We don't have the capacity to do that because the pressure at the front door is so high. But it is a case of how do we make every moment matter? And I think for me, it is this case of don't miss your opportunities to have genuine conversations with people. Really find out what is happening for them. If you're not naturally curious, that would be something I'd suggest to see if you can go and learn to be more curious, because that is what's going to stand you in good stead of providing patient-centered care. And I think that that saying that people won't remember what you did, but they'll remember how you made them feel is really, really important. And I think if you're seen as a safe place to land, someone that is whose integrity is intact, I know as a nurse on the floor, when I was working with patients, there would be times when someone would ask me something and I say, look, I'm really sorry, I am tied up right at this moment. Can you give me half an hour and I will come back? And I recognised that it was really important to make sure I came back, because if you don't, then your word means nothing. So it is that some of those values about that integrity, and it might have been that 30 minutes later I came back and said, I haven't forgotten you. I'm still caught up, but I haven't forgotten you and I am coming back to you. Patients then go, oh, that's someone I can trust. That's someone I can open my heart to when the opportunity is there to do it. And I think that that's what's really important is despite the environment being chaotic, busy, bells ringing, machines beeping, new patients entering a ward, is trying really hard to, if you've made a promise to someone, to circle back and at least try and close the loop on that. And it might be you get to the end of your shift and you just go, I've got 5 minutes now. I'm really sorry I haven't been able to give you any more time. Patients really appreciate the honesty. They appreciate the fact that you haven't forgotten them.
Right.
Kate, your expertise truly amazes me, really. It's clear that you do not only have a deep understanding of what needs to be done for each patient and caregiver at the right time, but also a remarkable sensitivity that allows you to connect on such a profound level. You're really a nurse. I can see that. I imagine this comes not only from your studies, I understand that, but also from an innate ability to empathize and truly feel what others need. It's inspiring to see such a blend of knowledge and heartfelt compassion in your care. How could you leave practice and because nowadays you don't practice nursing? Um, um, how do you could do that, because I can see you are an amazing nurse.
Thank you. Look, I think, there's something about an aging body. Nursing is hard on the body. Helping patients move, and my shoulders sore, my back sore, my
Okay, I
knees,
understand that.
So that is probably the how. How can I step away? But have I given up my clinical? No, I haven't. So I am the director of nursing in the department. And so I use my clinical skills now to establish programs of work. So we get funding that comes in to do, so the most recent funding was to improve palliative care into residential aged care for our older people that are in nursing homes. And actually having my clinical skills to really assess, and my research skills too, work that's been done prior to this funding, and whether or not it had worked, and was there an opportunity to innovate and think of something different. And so we actually went against the other states of Australia and decided to give our funding to the residential aged care, so the nursing home. And they developed their own leadership and expertise, which all the other states had given their money to specialist palliative care to go and service the aged care homes. We actually we did the reverse of that and gave it to the aged care home so that they could have a sense of pride about the fact that palliative care is something that they do in their aged care world. 85% of residents in a nursing home in Australia will die there. And so they need to be skilled in palliative care. So I feel like I am still able to bring my passion and my drive for really good nursing care, but see it now translated into policy. And I think probably something that may resonate for you, Annabella, was when I first became a nurse manager. Often in nursing, if you're a very good nurse, you get promoted, but you get promoted into management. You don't get promoted into clinical. And so one of my first promotions was into management, and I would be managing the nurses' rosters and their annual leave and all of those things that need to happen. And I recognized that actually I was still being a nurse because I was caring for the nurses. And if I cared for them, then they could turn up to work and care for the patients. And now I'm in bureaucracy. I think if I can care for the system and make the system better, I'm still caring ultimately for patients, because it's the innovation and the drive to really put significant money into practice that can make a difference. That is what keeps me from thinking, I'm no longer at the bedside, but I still feel like I'm clinically
Another level.
connected.
Yes,
Yeah.
another level.
Yeah.
Very good.
Thank you so much, Kate. So we're reaching the end of our time together, but we would like to thank you so much for coming on board, having a chat. I was missing you so much already. And
Such a pleasure.
yes, so we for the people watching, we will continue tomorrow in our journey through the changes in cancer landscape and lifestyle medicine in cancer. So for now, we would like to say goodbye. Thanks for listening. Thanks for joining, and see you tomorrow.
Thank you so much.
Thank you, Kate. See you.
See you.
Thank you, everybody.
Thank you, Ivor, for joining today. And we'll continue.